Hello, Assalamu alaikum. It's me, Dr. Muhammad Naseem Shirzad, and today I am going to discuss one of the urological emergency, and that is the priapism. We will discuss the basic concept of priapism, the pathophysiology of the priapism, and then we will discuss the management of priapism in detail. By definition, priapism is a persistent penile erection that is continuous for more than 4 hours in duration and the absence of sexual stimulation. There are two basic types of priapism. One is called the ischemic priapism, which we also call the low priapism or veno-occlusive priapism. The second is the non-ischemic priapism, which we also call as the high flow priapism or arterial priapism. We will discuss the difference between these two in detail. The differentiation of both ischemic and non-ischemic priapism is important, and it can be differentiated from one another on the basis of the history, on the basis of examination, on the basis of ABGs, and on the basis of Doppler ultrasound. If you ask about the history of the patient, in case of ischemic priapism, we can ask about the detail regarding the various hematological causes like sickle cell disease, like leukemias or coagulation disease. There may be some malignant infiltration of the corpora, especially in leukemia. Maybe the patient has used a total parenteral nutrition, or maybe the various type of medication like temsolizine, like testosterone, like alpha agonist, terazosin, doxazocine, or some antipsychotic medication like fluoxetine, sertraline, and olanzapine. It can also occur in case of hyperosmolar IV contrast, or maybe because of present spinal cord injury, or because of spinal or general anesthesia. While in case of non-ischemic priapism, it is much of the time is caused by the trauma, and there is a creation of a fistula between the cavernosal artery and the corporal tissue. So the most common cause of the non-ischemic priapism is blunt perineal or penile trauma. So this is can be differentiated on the basis of the history. Now coming into the examination. On examination, in case of ischemic priapism, the corpora cavernosa are fully erect, rigid and tender, but the glans and corpus spongiosum are soft. Secondly, if we aspirate the blood from corpora, it will be very dark and old blood. While in case of non-ischemic priapism, on examination, the corporas are partially erect and non-tender. The glans and corpus spongiosum are soft, and if we aspirate the blood from the corpora, that will be bright and red. So this is on the basis of examination. Now if we perform the ABG during initial treatment, so in case of ischemic priapism, there will be hypoxia along with hypercapnia and acidosis. So the partial pressure of oxygen will be less than 30 mm of Hg, so there will be hypoxia. The carbon dioxide level will be high, and that will be more than 60 mm of Hg. It will be showing hypercapnia, and the pH will be low, and means will be showing acidosis. While in case of non-ischemic priapism, there will be no hypoxia, means the carbon oxygen level will be more than 90 mm of Hg, while the carbon dioxide level will be less than 40 mm of Hg, and the pH will be normal. The last is the Doppler ultrasound, and that will showing us the blood flow. While in case of ischemic priapism, there will be zero or very minimal flow, but in case of non-ischemic priapism, it can show us the fistula, or it can show a high or normal blood flow. So on the basis of this, we can differentiate ischemic from non-ischemic priapism. Now let's discuss the management of ischemic priapism. Ischemic priapism is an emergency and it requires immediate treatment. And the most important thing is the duration of ischemic priapism. If it is more than 4 hours, it will lead into cavernosal smooth muscle necrosis, cavernosal fibrosis, and erectile dysfunction. So it means that the longer the duration of ischemic priapism, the higher will be the rate of erectile dysfunction. For example, with the early intervention, I mean if it is less than 12 hours, the erectile dysfunction may occur in 50% of cases. But when the ischemic priapism is present for 24 to 36 hours, the rate of erectile dysfunction will be 65 to 90% of cases. But in case when a patient presents with more than 36 hours, there will be almost 100% of severe erectile dysfunction. And when a patient presents for more than 48 hours, then the intervention can only allow the erection and pain to subside, but will probably not prevent erectile dysfunction. So, in case of more than 36 hours, there will be severe erectile dysfunction, and if it is present more than 48 hours, then there will be complete erectile dysfunction, and we will be unable to prevent it after 48 hours. So ischemic priapism that is lasting beyond 4 hours, that is similar to the compartment syndrome that is characterized by the development of ischemia within the closed space of the corpus cavernosa, which severely compromise the cavernosal circulation, and this is emergency medical intervention is required in order to reduce this smooth muscle necrosis, corporal fibrosis, and the development of permanent erectile dysfunction. So the duration of ischemic priapism represents the most significant predictor for irreversible consequences. So, if I summarize the etiological factor for the development of priapism, as the ischemic priapism is 95%, so the etiological factor for ischemic priapism, it is much of the time idiopathic, and there are some hematological causes of ischemic priapism, that is including the sickle cell disease, thalassemia, leukemia, multiple myeloma, and hemodialysis can lead into ischemic priapism. There are some infections which are producing toxin, and that's toxin mediated lead into ischemic priapism. That includes scorpion sting, spider bite, or rabies. There are some metabolic disorders that can lead to ischemic priapism, which is include amyloidosis and gout. The various neurogenic disorders that leading to ischemic priapism include spinal cord injury, maybe there is cerebral vascular accident or brain trauma, or spinal or general anesthesia. Multiple malignancy because of metastasis or regional infiltration can lead into ischemic priapism, that include CA prostate, urethral carcinoma, testicular tumor, or bladder growth. The various medication that can also lead into ischemic priapism, that include vasoactive erectile agent like piperine, pentolamine, prostaglandin, agonists like alprostadil, or the combination of intracavernosal therapy. Various type of adrenergic receptor antagonists that include tamsulosin, doxazosin, terazosin. There are various anticoagulants like heparin and warfarins, multiple antidepressant and antipsychotic like fluoxetine, sertraline, lithium, clozapine, risperidone, olanzapine. This can also lead into ischemic priapism. The antihypertensive medication including hydralazine and propranolol, various type of hormone like testosterone, and the recreational drug like alcohol, marijuana, and cocaine can also lead into ischemic priapism. Now let's discuss the management option for ischemic priapism. The initial conservative measure include if the patient is complaining of pain, local anesthesia to the penis is given, and then we will insert a wide bore 16 to 18 gauge butterfly cannula through the glans and to the corpus cavernosa directly or laterally at 3 and 9 position. After that, if it is not resolved, then we will aspirate the blood, and that should be aspirated around 100 ml until a bright red or arterial blood is obtained. If it is not successful, then we can go for cavernosal irrigation, and we will irrigate that with 0.9% normal saline solution. If it is still not relieve the condition, then we will go for next line management, and that is include the intracavernosal therapy. and the intracavernosal injection of adrenogenic agonist, and currently the first line therapy is phenylephrine. We will discuss that why phenylephrine is best and what are the doses of this phenylephrine. The other is the surgical therapy, and surgical therapy include the second line management, and that is the surgical shunting or penile prosthesis. So why we are using phenylephrine? Because phenylephrine is the most having a good safety profile and having high selectivity for alpha 1 adrenergic receptor, and having no concomitant beta mediated inotropic or chronotropic cardiac effect. That's why it is safe, having safety profile and highly selectivity. That's why we are using phenylephrine. And the phenylephrine is available in market with one vial contain 10 milligram per 1 ml. It means that the vial consists of 10 milligram and there is a 1 ml solution. It means that 1 ml contain 10 milligram or 10,000 microgram. So if you want to take 200 microgram, we will take 0.2 milligram from 100 milligram injection, and we will mix it at 9.8 ml normal saline, and then we will inject 1 ml, and 1 ml will be containing 200 microgram. We will inject it every 3 to 5 minutes until detumescence is achieved. The maximum adult dose is 1 milligram or 1000 microgram, and it should be given over 1 hour. Now we will proceed to the surgical treatment only when the blood aspiration or intracavernosal injection of sympathomimetic drug have failed. Then better to perform a distal shunt as compared to the proximal shunt, because there is a high risk of erectile dysfunction in proximal shunt as compared with the distal shunt. And then we will only use proximal procedure in case of distal shunt failure, in a condition when present in less than 48 hours, or in a patient who don't wish to proceed with immediate penile implant. In that condition, we can go for proximal procedure. And discuss the implantation of penile prosthesis in case of delay presentation, I means more than 48 hours, and in case refractory to injection therapy and distal shunting. We will discuss the shunting in a detail later on. The various type of distal shunt include, you can remember this by mnemonic, that is WEAT, WEAT. W means venter shunt, E means Ebhach, and A means Algoreb, and T means T shunt. Mostly we are using a T shunt because it is easy to perform, in which we are inserting a 10 number blade scalpel through the glans. And the other is the venter shunt. And venter shunt, we are inserting actually a true cut biopsy needle into the glans and excise multiple cores from the distal corpora, and this is the most least effective shunt. The Ebhauch involve a scalpel through the glans and making multiple puncture through the distal corpora. So if we perform puncturing with the blade, that is called T shunt, and if we perform it with a scalpel through the glans and making a multiple puncture through the distal corpora, that is called Ebhauch shunt. The Algoreb shunt involve a 2 cm transverse incision is made in the dorsal glands of the penis and distal to the coronal sulcus. The proximal shunt involved the Quakel shunt and the Grahek shunt. Now let's discuss the non-ischemic priapism, which is also called high flow priapism or arterial priapism. The Doppler ultrasound may be able to identify the cavernosal artery fistula. However, the arteriogram is the gold standard for the diagnosis of non-ischemic priapism. Non-ischemic priapism is not an emergency, and in case of approximately 62% of the cases, it will result without any intervention. If the non-ischemic priapism does not resolve spontaneously, or if the young patient wished treatment, then perform arterial embolization. But if the patient is not a candidate for embolization, or if repeated embolization fail, then we can go for surgical fistula closure the last treatment. Now, in case of erection from anesthesia or spinal cord injury, these typically resolve within 4 hours. However, if the erection does not resolve within 4 hours, then evaluate the patient and treat the priapism in the same and usual manner as we have treated the ischemic priapism. So now let's discuss the last option for ischemic priapism. And there is no clear-cut indication for immediately implanting a penile prosthesis in a man with acute ischemic priapism, although it can be considered in a male with a delay or refractory priapism. Some of the relative indication for ischemic priapism include if ischemia that has been present for more than 48 hours, and if there is a palaver of aspiration and sympathomimetic intracavernosal injection and delay priapism means more than 48 hours, and if the MRI or corporal biopsy showing the evidence of corporal smooth muscle necrosis or the palaver of a shunting procedure, although in delay cases I means more than 48 hours, implantation might be considered ahead of shunting procedure, and refractory priapism in a patient who have undergone shunting procedure. Now, the optimal time for implantation is within the first 3 weeks of priapism episode. But if a shunt procedure has been performed, the penile prosthesis implantation can be further delayed in order to allow the reduction of edema, wound healing, and risk of prosthetic infection. During this waiting period, a vacuum device is used to avoid fibrosis and penile shortening.